In orthodontics, historically, a lot of whether or not a case was a good finish was very much judged by how the two models sat together. And we lose a lot of references when that's our only metric to judge a successful orthodontic outcome.
Hey, welcome to Dental Digest. I'm your host, Dr. Melissa Seibert. In this episode, we're going to be talking all about facial and airway growth and development. We'll talk about how improper development can lead to diseases and conditions like sleep apnea. In this episode, we're going to answer questions such as how poor growth patterns can lead to conditions like excessive gingival display, or a gummy smile, a deficient mandible or maxilla, or TMD. We'll also discuss the role we as dentists play in all of this. My guest this week is Dr. Rebecca Bockout and Dr. Michael Gunson. Dr. Bockout is a board-certified orthodontist and periodontist. She's an affiliate assistant professor at the University of Washington, maintains a private practice in Seattle, and is faculty at Spear Education. Dr. Gunson is a board-certified oral maxillofacial surgeon, resident faculty at Spear Education, and lectures nationally and internationally on topics related to orthodontic surgery, OSA, and facial aesthetics. All right, let's jump in.
Welcome to Dental Digest. This is a podcast devoted to following evidence-based dental literature. Here's your host, Dr. Melissa Seibert. She's a dentist currently practicing in the Air Force. With that being said, nothing contained within this podcast is intended to be reflective or endorsed by the U.S. Air Force.
You all co-founded the Healthy Growth, Healthy Faces seminar, and one of the first things you do is define what a healthy system is. So would you all start by defining what that is for us?
Sure. Well, do you know where I'll begin? I'll actually begin with why I think we gravitated to healthy growth and healthy faces. And that's because we have a word that it's a pet peeve of ours that gets used an awful lot. And the word is normal. And we came to realize that treating to normals in our modern society is probably not the best solution, given how, at least we are finding anthropologically, our faces are not becoming healthier in time. They're actually becoming more unhealthy. And so as the gross population becomes more unhealthy, then your normals actually become more unhealthy. So we thought, we can't really talk about normals in that way, nor should we really be treating our patients to some normal that's been defined by a population when the patient who's sitting in front of us wasn't part of that study at all, didn't belong in that study, probably facially or growth and development wise, might not match what is considered normal or inside the bell curve of those studies. So I think that Becca's background is she knows so much about health and growth and development that it just made sense that when one has healthy growth, one has a healthy face. I would say that's where the name came from, and that might help understand a little bit about a healthy system, is that we're looking at healthy systems, not, quote, normal systems. As far as what makes for a healthy system, it's a face that works the way that it's supposed to. And I found that in looking at anthropological studies and other things, that the face really has I talk about three basic functional keys, which is in the order of their importance: breathing, eating, and communicating. But there's actually a fourth one, and that's, and I don't talk about it much because it can lead into other topics, but it's procreating. So it's anthropologically and evolutionarily, we are meant to propagate the species. And so as we breathe, eat, and communicate, we present ourselves, if we do it in a healthy way, we present ourselves in a way that attracts a mate, and then we can have offspring that are also healthy. So those are the jobs of the face. And so if it works the way that it's supposed to, that's considered a healthy face.
And so Mike sees the patients when there's been so much breakdown in that system that the only option is surgery. And what we find interesting is how do we take that all apart and figure out the why? Why did that happen? What was the breakdown that caused the system to end up such that they now need surgery? And where did the breakdown happen, and at what stage can we intervene? And it's not just breathing, it's not just speaking, it's not just tongue, it's not just the foods that we eat, it's everything. And it's a whole system. And so understanding how the system works is key to putting it all back together. And likewise, if I orthodontically move teeth into a new position and I don't understand tongue and tongue space or joints, or if Mike similarly does the same, if he puts all the pieces back together but doesn't look at how the system is able to function, just because the teeth fit together on a tabletop doesn't mean that the system works and works with longevity and stability.
How are teeth supposed to fit in appropriately for the proper tongue space?
Well, I mean, I think as dentists, that was the first class of my dental career. I remember 8 o'clock in the morning sitting in occlusion, dental anatomy and occlusion, and where all the dots are supposed to occur. So nature has put together this system of teeth and how they're supposed to fit. There's reasons for those cusps and inclined planes and all those things that we ever learned about. Those things exist for very specific reasons. And so I think extrapolating system-wise, sometimes if we focus solely on cusps or individual teeth, we lose the importance of their interaction with each other. And then if we only look at the interaction of the teeth, then we lose the importance of how that tooth is supposed to actually sit in the bone that it's been given. But if we only look at how that tooth is supposed to be sitting in the bone, then sometimes we don't see how that bone is supposed to be sitting in the face, or how that bone is supposed to be supporting the airway. So when you simply talk about bite or how the teeth fit, it's important, but it's, again, only part of the system. The system's much larger, and you can even extend it further than that. It's not only how the bones sit in the face, but then what is the face doing? And how does the face's actions, how do the face's actions influence other parts of the body, such as posture, breathing, how it affects diet, the diaphragm, the intercostal muscles, lower back. I mean, we can go all the way to the toes. In fact, I taught a course with some friends of mine, and we called it lips to teeth to toes, because we felt like the whole system gets affected when something's off.
To add to that, in orthodontics, historically, a lot of whether or not a case was a good finish was very much judged by how the two models sat together. And we lose a lot of references when that's our only metric to judge a successful orthodontic outcome. Something that Mike taught me to really look at is the importance of getting lips together. And so if the teeth fit together, but there's, for example, a vertical maxillary excess mandibular retrognathia, and the lips cannot come together, just because the teeth fit together doesn't mean that's a healthy patient. Similarly, if the teeth fit together, but there's so much protrusion that the lips can't come together, that's also not a healthy situation. So understanding the system becomes important. And so it's lips, it's joints, it's tongue, it's nasal breathing, and then, of course, posture as well. And as humans, we're driven to do certain things, like Mike mentioned at the beginning. We will do whatever it takes to breathe. And the nose and the mouth are not the same. And that is a little bit of a newer concept, even in medicine. People say it doesn't matter. You can breathe through your nose, you can breathe through your mouth. As long as you're breathing, you're doing just fine. But we know in orthodontics, in surgery, in dentistry, that if we breathe through our mouth, it's not the same. We get breakdown. Breakdown can be gingivitis. Breakdown can be high caries. Breakdown can be swollen turbinates. It can be inflammation in adenoids and tonsils. And then that leads to further compensations. The more and more we as children spend with our mouth open, we have a displacement of the condyle and the fossa. We have a longer downward rotational growth of the lower jaw. We can see gummy smiles, and all of this happens really, really early. And so when we understand how the system can work in harmony, that's when we can start to rehabilitate a patient.
I think Becca's point is really important in how absolutely essential it is to understand what healthy looks like. Because from there, when we know what a face is supposed to do, when we know how people are supposed to speak, when we know, that the lips are supposed to come together, so that when we look at somebody and we see that the parts are off, or that the functions are off, like when we as a clinician can appreciate when a patient comes in and all of a sudden they have this lisp that they haven't had before, we have to stop and say, well, where'd that come from? And what's going on in their face and their mouth that caused that to happen? Or patterns. And this is where Becca and I, our course is really, I think, strong, is identifying patterns in children, patterns in young adults, patterns in older adults. These variations and steps away from what's considered healthy. You see these pathological patterns in people, and it then really helps inform where to look for in the parts, right? So you have these abnormal pathological patterns, and then, well, if that's going on, what can I expect to see in their mouth, in their airway, in their jaws? Becca brought up putting the lips together, and it's funny how old of an idea that is. I think when I initially lectured on it, I used the book from 1880, called Shut Your Mouth and Save Your Life. And this guy knew, and he was a painter that went around with the Indians and was able to notice that those that lived on the American continent, the indigenous, they all slept with their mouth closed, and how it made for a different looking face than the Europeans. But I mean, we can even go to older literature with us. For example, Ricketts in '68 was talking about lip incompetence and how it creates an unpleasant appearance and the illusion of a weak chin. And even talked about how it can be embarrassing for patients not to be able to put their lips together. So these are things that we've talked about for a long time, but maybe we haven't put together in a diagnostic way, right? To help aid in our diagnosis and therefore our treatment planning. Because I know for me, nobody ever really said, hey, when you do jaw surgery, make sure the lips touch when you're done. And it's made all the difference in my facial results and in how happy my patients are. So,
could you all paint a picture? What would be the ideal human? How would they ideally develop so that they are perfectly healthy? What are some of the things that you'd be looking for?
We want to think about, we have a lot of different facial dimensions. So forward back, we want to make sure that both jaws are forward enough, which supports the lips, which also supports tongue space, which supports airway. We want to make sure things are wide enough. The width also supports the tongue, but also the roof of the mouth is the floor of the nose, so the width also supports nasal breathing. And then vertically, we want to make sure that there's sufficient vertical space for the tongue and the teeth, but also not excessive vertical space such that the lips can't come together. So it's finding that balance. And there's not I wouldn't, and maybe you can weigh in on this too, Mike, I wouldn't say there's a cookie cutter person, but it's rather making sure that the person fits. So people ask me, for example, what's the ideal width of the maxilla? And I don't know that we have we don't have a millimeter metric, but we do have to make sure that we're confined a little bit in terms of the width by the width of the lower jaw. And I'll see some really wide lower jaws, and then that upper just needs to be wider than the lower. But the width of the lower jaw is probably formed by the tongue. And so we just need to make sure that we can accommodate the tongue.
Yeah, and I love that too. So as Becca was talking about coming forward, being wider, and controlling the vertical, in my brain, I'm thinking of, well, you talked about an ideal person. So in my brain, I'm thinking, well, what would that look like facially, right? So if the jaws are forward, as Becca said, supporting the lips, what do the lips look like? Well, they're supported, which means that the vermilion or the pink part of the lip is pushed forward further than the rest of the lip. Well, what do people spend billions of dollars on every year is to have those lips filled to show more pink. But in reality, if the teeth and jaws were actually supporting them correctly, they would probably have it. The next one is like, how much width? Well, everybody wants a broad smile. They want to see those front teeth. And in order to get that, well, you need the width. And then also people, again, like to see lips that are not straining and projected. but there's no way to project your lips in your face if you're spending the whole time trying to squeeze them together. They get thin and flat. They don't look right. So, there's a reason why on the cover of most fashion magazines that the models are class 2, division 2, because their faces are overclosed, and with their faces overclosed, the lips, they push forward. As Becca's commenting on this healthy growth and development in kids, well, to answer your question of what an ideal human looks like, well, with that growth, those are some of the outcomes. But also, somebody that can breathe well. We can identify people running around with bags under their eyes, looking half asleep, faces drawn. We called these the adenoid faces for a long time. It's more than just adenoids. It's not just the adenoids that made that face, but we are judging their health and saying that person's not really healthy. Well, yeah, because they don't breathe right. So there's an aesthetic outcome, whether positive or negative, depending on whether the pattern behind it is pathologic or healthy. And it's that connection or that pattern that if we understand that as a clinician, one, I think makes it more fun to be a clinician because we see these, I love patterns and I love connections, but it also makes us better because we treat as a whole, and it makes for a longer lasting, more stable result, happier patients, better looking patients.
So this is a concept that you and I, Dr. Barkow, talked about quite a while ago when we recorded an episode in the summer, but we've had a ton of new listeners, and this is really important. This is a topic that's talked a lot about in dentistry, and there's also a lot of misinformation out there. So why is it important to be a nasal breather?
So the nose is a natural filter. It filters the air, moistens the air. It produces nitric oxide. It increases lung elasticity. And in a growing child, let's play out the reverse. If you have a child that is mouth breathing. So in kids and in adults, we run into a lot of the chicken and egg question. So would a child be a mouth breather because adenoids and tonsils are enlarged, or are adenoids and tonsils enlarged because a child is mouth breathing? I think we understand a lot more about inflammation today too. So if we think about, first, I do think there are some kids that might have a sort of a hyperimmune system. Maybe it's cytokines. Maybe they're kids that have a lot of food allergies or environmental allergies. Maybe these kids just their immune systems are a little bit hyperreactive. These kids might be more mouth breathers. They might have a history of eczema. But so then they start mouth breathing. So now you lose that nasal filtration. And then you start to see breakdown. You see low tongue posture. It's the lips coming together. It's the tongue coming up and forward that forms the width of the jaws and the forward back direction of growth. And so now you have this mouth hanging open. You have lack of tongue pressure in the roof of the mouth, and you start to see crowding. You start to see narrow jaws. You start to see flaccid musculature. And now you start to see other habits, other patterns. Now mouth breathing may or may not become habitual. There's poor sleep quality often associated with these kids. We have small airways. Adenoids and tonsils can continue to be hypertrophied. And then you get poor sleep quality in these kids. So then you have sometimes behavioral components, and it becomes very cyclic. And it's hard to undo all of that. And then sometimes also, and this is a whole nother area, if there's a tongue tie, we don't get that upward movement, upward mobility, and we don't get a full swallow in a really young child. And so we get that underdeveloped maxilla at a very early age. And that also can kick off sometimes a negative growth cycle, so to speak. And so expansion alone, for example, doesn't rehabilitate a child. We have to understand all of these pieces. So Barry Raphael said something that really resonated with me, which is structure, function, behavior. And Mike and I talk about this too, because it's true for jaw surgery like it's true for the children. We as orthodontists, as surgeons, we can control the structural piece. We can move the bones, the teeth, but function is, does it work? Can the tongue come up? Can the lips come together? Can a patient breathe through the nose? And then behavior is, Are they able to do it on a habitual basis just because they can? Are they doing it? And so then we really start to bring in this whole idea of interdisciplinary or multidisciplinary care for these patients. It's not just the orthodontist, it's not just the surgeon, it's myofunctional, it's speech therapy, it's breathing re-education. There's a lot of components to getting the system to be healthy when it has a history of not being healthy.
So, my portion of the puzzle is, you asked how important nasal breathing is. When you have patients where it's difficult for them to nasal breathe, meaning they can't put their lips together very easily, you take that person and you give them 20, 30 years of pursing their lips together, and the aesthetic result will be a long upper lip, a thin upper lip, deep nasolabial folds, a very thick and pointy mentalis muscle. So I've mentioned now some facial changes that occur, vertical lines, vertical striations in the upper lip. These are things that are often sought out to be treated by going to the cosmetic surgeon, to have fillers, to fill the nasolabial folds, to make the lips thicker, to Botox the chin. These are common procedures. Well, where did they come from? They came from the kids that Becca was just talking about. These are the adults that show up. Well, let's add some more to it. Let's talk about posterior tooth contacts and tooth wear, where the posterior molars are now getting flatter and flatter, or they fracture and need a crown, or they fracture and are extracted. Why did these facial types, why are they missing their second molars so often in late adulthood? And then you go from there. Why do these patients often on MRI have anterior displaced discs? There's a lot of debate about it, but can we not imagine that somebody who has to posture their jaw forward to close their mouth from childhood, can we not imagine that their ligaments would be elongated and the disc would be deformed in an anterior position from that constant translation of the condyle? Probably. So, your question was about nasal breathing, and we just presented to you a lifetime of pain and problems. The good news is that humans are pretty resilient. We can get to 60-year-old and have all these problems and just accept it as being wear and tear. But when you start talking about these things and what they have endured in their lifetime with patients, they're like, yeah, I understand. Well, you're hitting on your back teeth. Yeah, I feel that. Yeah, you have to purse your lips all day. Yep, that's annoying. You posture forward. Your mother yelled at you when you were a child all the time to stand up straight. Yep, that happened. And then you tell them, your brain would never let you stand up straight. Doesn't matter how much your mom would yell at you. So all because what? Because they can't get their lips together. They can't breathe through their nose.
So why now? This has become a topic that is really kind of exploding in dentistry. There's a lot of discussion around it. Why are we seeing, though, perhaps these changes in human beings just in recent history?
I think some of the work that Mariana Evans has been doing, looking at anthropologic skull data from the University of Pennsylvania, is there's a clear demarcation when sugar has been introduced to the human diet. And so as soon as post-industrialization, once we started adding refined sugars, soft food, we saw a marked change in skeletal growth. And ever since then, our maxillas are getting smaller, our sinuses are changing size, our tongue space is changing, and our jaws are getting smaller, and we're growing downward and backward as a species. So diet plays a huge piece in this. And then you think about diet, you think about sugar, you think about inflammation. It can all be interrelated.
Can you speak to that a little bit further? What is it about sugar that's creating this change? Is it perhaps that it's so nutrient dense that we're maybe eating these softer foods, we're not chewing as much? What's the relationship there?
Using our muscles helps increase bone density. And so if we have a very refined diet, especially with children, with babies, a lot of sugar, we're not using the muscles in the same way. We're not recruiting muscles. Muscle development helps guide the growth of the jaws. The mandible grows, the most growth of the mandible occurs in the first 2 years of life. Maxilla is almost done growing by age 4. So a ton of this stuff happens early on. as a working mom, I was guilty of giving my kids things like pouches. You think about sucking, you think about cheeks coming in, low tongue posture. And I'll take a break from diet for just a second. And if we even think about things like non-nutritive sucking habits, I will see these kids at my kids' daycare walking around with pacifiers in their mouth when they're 2, 3 years old, or these things called wubbanubs, which is a pacifier with a stuffed animal attached to it, and it's just hanging from their mouth. And they walk around with this thing in their mouth every day. And then you have pediatricians and pediatric dentists or whomever in their world is saying, well, it's okay because we'll fix it when the adult teeth come in. And people don't understand that so much of this growth is occurring early. How that tongue fits up into the roof of the mouth is really what's going to drive growth. And so you have this thing pushing on the tongue, keeping the tongue low. That tongue never develops that muscle tonicity, that muscle memory to reach into the roof of the mouth. That's going to affect speech. That affects swallow. And that definitely will affect the position of the upper and lower jaw growth. It's documented that kids that are born in the NICU or born and kept in the NICU and are tube fed tend to have a small maxilla, cross bites, and they tend to develop airway issues later in life, even at year 1. And part of that is because that tongue never developed that pattern to swallow, to get into the roof of the mouth. And so we have these high, narrow palates, flaccid, low tone musculature. So I know it's not exactly your question. You asked about sugar, but we have to think about it's everything. And it's all like we talk about changes post-industrialization. What are we doing in our modern society? And what are we okay with in the name of what's normal? Is a kid walking around sucking his or her thumb till age 7? Is that now normal? Is using a pacifier because that's a coping mechanism? Is that normal? Or do we want to understand why? There's some literature talking about the nervous stimulation in the roof of the mouth as a human being's way to self-soothe. And so for a baby, we have this constant need to suck as an infant. And if there's a tongue tie, for example, that tongue can't get up into the roof of the mouth, so a baby will seek something else to stimulate the tactile sensation in the palate. We just have to understand these things. We think about speech patterns, and in a little kid, a speech impediment might be deemed cute and therefore not addressed until the child is now 8. And if we start thinking about what's going to happen if we have that forward tongue posture between the teeth for all these formative years, and at age 8, now somebody wants to address it, and we have a large open bite, that tongue keeps coming through. Imagine trying to retrain an 8-year-old and close an open bite.
Also, along the lines of that sugar question, I think it's funny. I was smiling earlier that when you brought it up, because it was on Saturday. I was at a museum and I took a picture of a statue from China from pre-industrial. I believe it was. I think I said it was from the 1400s. That face was absolutely bimaxillary retrusive with a deep bite, so overclosed. Well, that's pre-industrial China. So then, why? Anyway, that's a side note. But coming back to the idea of sugar, the idea of inflammation, you can't just also blame it on sugar. When you start moving into the more industrialized society, there are a lot of other things going on. More than, and maybe even more than diet. You have Europeans who are now living in close proximity, who the spread of bacterial infections, viral infections becomes more rampant. Inflammation goes up. You have a dramatic increase in pollution from industrialization. Inflammation goes up. You have advanced even further into the 1900s. You have the development of birth control pills, which of great benefit to the society, but at the same time, unbeknownst to many, it increases inflammation quite dramatically. And so we talk about normal, we can, with all this going on with inflammation, this inflammation is going to, well, let's talk about how it would affect the mandible. Inflammation in the mandibular condyle region will lead to resorption of the bone of the condyle. And during development, we might not see it as condylar resorption. We just might see it as a shrinking condyle or as a small condyle. So all this inflammation is really just insulting these kids who are growing, and they make for small mandibles. They get more of a clockwise rotation to the jaw, leading to small mandibles and an anterior open bite because of all this inflammatory environment that is going on around them. So not just food, in an industrialized society, it's really broad. And we can even go on now with the amount of hormones that are in our environment, how they affect our fish, and they end up in our fish, and then we consume fish, and when they end up in our milk and our cows, and what effect is that going to have inflammatory wise? And then finally, one last big one that is affecting many of our Generation Z and millennials is anxiety, and depression. We could simply chalk this up to stress, but activating the sympathetic system as much as our kids are being activated, you have to realize the sympathetic system drives inflammation as well. So you have these kids who are stressed out from birth until they're done growing. Of course, their growth's going to be abnormal. It's a very strong association for condylar resorption and sympathetic overdrive. I've seen it since I've started practicing, and I can see it in patients who come in vibrating. They're just vibrating. Their sympathetic system is like, and sure enough, small joints, open bites, small jaws. And I love that Becca brought up that whole idea of the thumb suck, because it is soothing. And why is it soothing? Because as you stimulate the posterior palate, you're activating the vagus nerve, which does what? It drives the parasympathetic system. So you have these kids who are on overdrive sympathetically, sucking their thumbs, trying to self-medicate by activating their parasympathetic system. So it's actually makes my mind kind of just spin all these interactions. But being aware of all of them, I think, helps us speak intelligently to our patients and parents, and make sense of things that sometimes parents, they come and see you and they want answers, and they don't want the answer to be, well, we can do this or we can do that. That's not what they're looking for. A lot of times they want to know why it's happening. And it's these kinds of discussions, I think, that are beneficial to the souls of those, to the hearts of those that we treat.
Hey guys, would you take just 5 seconds of your time to leave a rating and subscribe on whatever app that you use to listen to this podcast, whether it's Apple Podcasts or Spotify? Ratings actually really help. And as always, I love hearing from you, so send me a direct message on the podcast Instagram, which is Dental Digest Podcast. All right, I will see you next week. I commend you all for championing these ideas, because quite frankly, we're talking about a problem here that if it didn't exist, you all would not be gainfully employed. So that's kind of what's funny about all of this. But let me ask you this. When it comes to non-nutritive sucking, what recommendations would you make? Because this is just one small area that dentists can really be impactful. What should they be instructing the parents of young children on?
Well, and so I dealt with this with my first daughter. We did use a pacifier, and I think a pacifier is a healthy choice for a young baby, but probably past age 8 or 9 months, probably up to 12 months, they probably don't need it anymore. And so to either make the decision to wean the child off slowly, by the suggestion that was given to us was to start cutting bits off the top of the tip, so that after a week or so, they just forget about it. It doesn't provide that soothing comfort anymore. And so then we were done with it. So trying to get rid of the pacifier as early as possible before it becomes an emotional tie is really important. And then thumb sucking too, that one's harder because it's harder to take away. But the thumb, I would say, causes more damage because it holds the tongue down, but it also holds the mandible back. And so we get lack of mandibular growth. And I talked to Mike about this because I'll see 2, 3, 4-year-olds with a deficient mandible, 6, 7, 8-year-olds, and you just start to think, how is that ever going to catch up? It's unlikely to think that all of a sudden we're going to get 6 millimeters of forward mandibular growth if it's been slow that whole child's life. And so in orthodontics, there's a common belief of not treating the mandible until puberty. But I would say treatment doesn't have to be something like a functional appliance. Treatment can be looking at all the habits that are at play that are preventing it from growing forward. So like digit sucking, like lower lip entrapment, like speech, like a tongue tie, like swallow, what's happening that might be contributing to lack of mandibular growth, mouth breathing.
So what would your advice be then on thumb sucking? Should children ever be doing this?
I don't know that I'm going to come out and say don't ever let your child suck their thumb, but I do think that as parents, as providers, to be able to equip parents with the knowledge so they can help make the right decision for their child. All I can say is that pressure on the lower jaw and a digit up in the roof of the mouth is going to negatively influence skeletal growth, and to help find the tools to help someone move away from that habit in a safe and impactful way.
I think we have to ask, let's ask the scientific question. Does that body need a thumb in its mouth? Does our thumb exist for that purpose or that reason? And maybe, if you take ultrasounds of kids, they always have their hands up at their mouth. That might actually be, having the hand in the mouth is something that might promote jaw growth and function prior to birth and breastfeeding. Who's to say? We don't know. I guess the question then is when the baby is born and ought to be breastfeeding and ought to be functioning in a way to get the stimulation of the posterior palate, why then do they continue to thumb suck, right? Well, because they're missing something. They're missing a piece of the puzzle that has not allowed them to take the hand out of the mouth, even though the breast might be available, or even though the tongue should be there, but it's not. So should they stop thumb sucking? Well, I think we should think twice about, yelling at kids to stop doing it, because that's a brain function. That's the brain telling the kid, you got to put this thumb there or we're going to die. That's really the amygdala. The amygdala is telling the child, if I don't soothe myself with my tongue, I'm dead. I'm not really exaggerating. That's what's going on in their bodies, in their little bodies. So then you start yelling at the kid not to do that, and they're in what's been termed a double bind. And then now you're creating all kinds of stress. So yeah, diagnose the real problem.
Look for tongue ties. I think that's something, and I know that's controversial in some circles. Audrey Yoon wrote a beautiful paper that can give us all a language to talk about the functional component to tongue mobility, because it's not, is it tight or not tight? It's not, can you stick your tongue out or not? It's, is the tongue able to lift up and into the roof of the mouth? It's form, function, and behavior. It's, can it get up there, and is it doing it on a regular basis? And it's more nuanced than, is there a tongue tie? I think it's also, is there the muscle strength? Is there the muscle memory? Is it habitually going in the right position? And is there the motor coordination? Is there the motor patterns that have been established? Because I think that's also something that's a tricky piece. And so some of these children might need a little bit of help with OT, with PT, with myofunctional therapy. And it's not as quick and easy as just, like Mike said, we shouldn't be yelling at a child, don't do something. We should be helping give them the tools to cope and help understand the true etaology.
Very much like what Becca said too about what Dr. Yoon has written. And if we also look at, if I look at my experiences, for example, with Dr. Zaghi, who, his practice, his individual practice is very much made up of tongue release, but his go-to is myofunctional therapy. Unless it's blatantly obvious that the tongue is bound down quite completely, he's very much in favor of establishing the proper musculature tone prior to the actual cutting of the frenum. And I find this to be fantastic. Obviously, some patients can't gain complete musculature activity without having it cut, right? But you need to move down that path before just thinking surgery. It's much like expansion now. Everybody is singing expansion, and that's great because a lot of people need expansion, and that's fantastic. But what's the diagnosis? Like, what are we really treating? And if we approach it from a systems standpoint, then we're not just expanding for expansion's sake. We're trying to achieve a diagnosis first. Once we have this complete system-based diagnosis, then we can successfully approach treatment.
One of the common zeitgeists in medicine and maybe perhaps dentistry is that if you just take out a child's tonsils and adenoids, then it'll be purely curative. So is that notion, I mean, perhaps it is a bit antiquated. I know that that's not the direction we're heading, but is that misguided or a gross oversimplification of the problem? Because again, oftentimes these children with these issues, the parents they're not necessarily taking them to the orthodontist or the oral maxillofacial surgeon. They're taking them to the pediatrician or the ENT.
When I think in medicine, if a child has a diagnosis of sleep apnea, that's the number one thing that will be recommended in the event that that tissue is inflamed. And that is the fastest way to get a child to sleep better. So there definitely is a place for that and a need for that. And this is where interdisciplinary care is so key. Dr. Guilleminault wrote, and I believe this 100%, that let's say you'd have an 8-year-old child, enlarged adenoids and tonsils, 8 years of mouth breathing, 8 years of low tongue posture, jaw down and back. Of course, you're going to have craniofacial deficits. It would be near impossible not to. And so just by taking out adenoids and tonsils, you haven't solved the whole picture. You have to rehabilitate the craniofacial deficit, and you have to help with muscle retraining. You have to change the habits, change the structure, function, and behavior. I'll go back to that. So just because adenoids and tonsils came out, you haven't solved the problem completely. You've helped, and in a very important way, got that child to sleep better very quickly. Have I seen kids that have very little craniofacial deficits and still had adenoids and tonsils out? Yes. Have I seen kids that had adenoids and tonsils out and are still symptomatic and still have residual AHIs? Yes.
Yeah, and again, chicken and egg kind of problem. Becca had an article that just came out about how altering transverse can actually shrink tonsillar and adenoid tissue. So, addressing the structure then solved the soft tissue problem. Whereas before it was maybe, well, it's the soft tissue problem causing structural issues. Well, I think we're all adults. We can have it both ways. You know what I mean? We don't have to pick a dogma. Our bodies don't. Our bodies are extremely complex. Why would we expect everything to move in one direction? Great study, by the way, Becca. Thanks.
I was just a small piece of it, but thanks.
Yeah, actually, I'm really glad that you brought that up because I know Dr. Barker has to run in a second. Would you tell us about your publication? And congratulations, by the way.
Thank you. A huge shout out to Dr. Yoon, Dr. Stanley Liu, Dr. Christina Hong, and all the other collaborators on that paper. Dr. Yoon and I were talking during the COVID shutdown, and we both have noticed in our pediatric patients, we've had patients where we did see adenoids and tonsil enlargement in our CBCT scans pre-treatment, and then we saw them shrink after treatment. And we said, well, maybe we should collaborate and look at our data together. And she had a very interesting data set because she had, I think it's up to 20 patients that were scanned with the CBCT, and then the COVID shutdown happened. And then a year later they came back, and then we took a new CBCT. And so we have this sample of about 20 untreated patients with two X-ray time points. So we're able to now compare age-matched children to this untreated sample and to say that yet the only intervention with our sample patients is expansion, nothing else. And so expansion at 2 time points compared to no expansion with the same time interval, we definitively showed shrinkage of adenoids and tonsils, not just an opening of the pharyngeal airway space, but an actual shrinkage of the volume of the tissue. And so we collaborated with radiologists, with ENTs, and a lot of people helped us with our measurements to make sure that everything was very accurate, to understand how we were exactly measuring these changes. I hope that this will continue the collaboration between medicine and dentistry, because it's very powerful when we all can work together. It's not just take out adenoids and tonsils. It's not just CPAP. It's not just mandibular appliance. It's all that we can do in dentistry to help work alongside our medical colleagues when we are talking about sleep apnea.
Going back to the Healthy Growth, Healthy Faces seminar you all formerly put on, you all recognized troublesome growth patterns such as crossbites, excessive gingival display or gummy smiles, a deficient mandible and maxilla, TMJ disorders, and an open bite as problematic. And, some of this is obvious, such as a deficient mandible or maxilla, but can you tell us, how is excessive gingival display or a gummy smile or TMJ disorder, how is that a result of growth pattern?
So it all goes back to mouth breathing. So picture your blank slate child, that lower jaw comes down and back. Teeth always want to touch. So the posterior teeth start to super erupt. Lower jaw continues to drop down and back. You continue to have that downward backward growth of the lower jaw. And then you get continual vertical drift of the entire maxillary complex. And then you look one day and you have a kid with a gummy smile. What I think is also a point I really want to get across. When I was a restorative dentist, a lot of the CE content I went to addressed the gummy smile. It was a very hot topic in the CE that I was attending. And all of the photography was looking at the patient straight on. Smile, repose, but at least in the courses I went to, it was never addressed that this is a 3-dimensional issue. It's not just that there's a longer lower facial third. There's a mandibular retrognathia to a gummy smile. And there's a change in the occlusal plane that I didn't know to look for that. And so it's a downward backward growth pattern. It's not just vertical maxillary excess. What did we talk about, Mike? Well, I think we said it's a syndrome.
Yeah, I think the term was. I think you had the citation of long face syndrome. What is that? A turn of the century idea? And I mean last century, my century, not this one. So the idea of a long face syndrome. Why do people have long faces? But I think to answer the question about condylar changes, I think the temporomandibular joint is just you can tell how little we know about it by how angry people get at dental meetings, because we don't get mad at each other if we understand things like sleep apnea is bad. Oh yes, I agree, sleep apnea is bad. And we all pat each other on the back. Yeah, we need to solve sleep apnea. But then we start talking about the TMJ and tomatoes start flying and people get angry, mostly because we have no idea really what's going on up there. But if we start paying attention to patterns and we pay attention to how the condyle moves, how it functions, something really simple, for example, when one of the pejorative terms that we use is we call it the disc. It's not a disc. This is like a hat. If you actually saw it, it looks like a disc in 2-dimensional imaging, right? You do the cross sections on an MRI, it looks like a disc. Yeah, that looks like a disc. It's not a disc. It's like a hat, a cap that sits over the top of the joint. And in that regard, if you start thinking of it that way, and then you start thinking of how it's attached to the joint and what the capsule's made up of, and then how it moves and functions in speech, not just, sometimes we get stuck with this whole idea of bruxism hurting joints or malocclusions hurting joints. What about talking? We do that far more during the day than we do putting our teeth together. Dr. Coyce, just this last week at AARD, he said, how many times have you heard of somebody waking up with a broken tooth? And I was like, yeah, I don't think I've ever heard that. But how many times has somebody broken their tooth during the day, right? Almost always. I don't know. I mean, that's kind of a gross generalization, but yeah, maybe our daily function, our speaking, chewing, and all those other things are probably, maybe they're creating more pressure than we actually think. So then that kind of activity, how does that affect our jaw joints? And so we have tools now. We have MRI, we have functional MRI, we have things like, which still has to be kind of proven yet, but things like mod jaw, which might show animation of the joint and how it moves in function and chewing, three-dimensional representation of how the jaws move. And, Dr. McDonald is doing incredible work on this. Just gave a lecture at ASAP on this, saw bits and pieces, and wow. So if we understand how that jaw moves and how the joint responds to it, I think we would do better with what we say, about the temporomandibular joint, instead of thinking of it as some kind of static thing with a displaced disc. We're kind of pigeonholed by the vocabulary that we've grown up with in some respects. For me, again, system thinking and pattern observation is the best way to approach anything, including the joints.
So then just to kind of round this out, let me ask you as well. And, again, I know this is controversial, so don't feel like you have to answer. Do you think that there is a relationship between bruxism and the airway? Again, going back to, I really appreciate your point that this is controversial and there's so much we don't know. And in one way you can gauge that is by how heated people get over these kind of concepts.
So I like stories. So can I tell you a story?
Please do.
So I had been researching this topic quite some time ago, and both bruxism and airway versus daytime clenching, mostly because for me in my studies, about 10 years ago, my studies were mostly focused on the condyle and the TMJ. So I was analyzing, what kind of forces, compressive forces, would alter the joint. So I was pretty heavy into bruxism, and one of the main chemical causes of bruxism, is actually selective serotonin reuptake inhibitors and selective norepinephrine reuptake inhibitors. So people who are on antidepressants get a lot of clenching during the day and bruxism at night. What's the mechanism? Well, the mechanism of the antidepressants causing bruxism and clenching is thought to be the dopamine component of those medications. So even though they put the word selective in front of serotonin or norepinephrine, it's really not super selective. And a lot of these drugs have dopamine activity. Well, dopamine causes rhythmic muscle contraction. So when you get too much dopamine, the body contracts. So that was my background. So then I go to Chicago to a meeting, and I meet this well-dressed guy who's talking about the sleep apnea triad. So he's talking about bruxism, acid reflux, and sleep apnea. Well, that's Jeff Rouse, right? And the first time I heard him, I think it was 2008. And he's up there talking about, and I'd not put together acid reflux as being part of this, but I knew that sleep apnea was causing bruxism, at least according to some of the studies. And when he threw in acid reflux, I was like, oh, well, acid production in the stomach is mostly moderated by serotonin. So then you start thinking about what happens when somebody has sleep apnea. What happens is when you stop breathing, the body goes into a stress response and it secretes sympathetic related hormones. What are they? Serotonin, norepinephrine, epinephrine, dopamine. They get surged. So Jeff was talking about how bruxism was a means of the body waking itself up from an episode. I was like, whoa, no, maybe it's the dopamine surge, right, that comes from not breathing, that then leads to these extreme rhythmic contractions. And you have to be aware it's not just bruxism. So people who have sleep apnea have other issues. They get carpal tunnel syndrome. And why do they get carpal tunnel syndrome? Because when they go into their apnea episode, they do this. And then they get tennis elbow. And why do they get tennis elbow? Because when they go into their apnea, they do this. They also get plantar fasciitis. So why do you think they get plantar fasciitis? Because they point their toes at night. and their legs contract. So they go into these rhythmic contractions because of dopamine. That's my thought. And it fits very well what Jeff was saying. So I remember running up to him afterwards. I was like, oh my gosh, thank you for that. Let's talk. And the rest is history. So that's one component. And so to answer that question, very short question with a very long answer, yes. I think dopamine is definitely responsible for rhythmic contractions, including bruxism. And I believe that many patients who obstruct undergo dopamine surges. And a lot of other things can be explained, like depression from sleep apnea can be explained by receptor changes as a result of serotonin surges. And ADHD can be explained because of receptor changes as a result of epinephrine and norepinephrine surges. So you have kids who sleep, obstruct, release all this adrenergic hormones. The receptors are swamped. So what does the body do? It decreases the receptors, right? But now you have a kid who has to go through the rest of the day with fewer receptors. So they're inattentive. The frontal cortex isn't processing the way it should because there aren't enough receptors to activate the frontal cortex. So what do we do to these kids? We give them amphetamines, right? To occupy whatever few receptors they have left. All of this can be explained, at least in that regard.
Can you speak to upper airway resistance syndrome? What are your thoughts on that?
I don't know that I'm the guy to talk about that. I will say just a few things about it that it leads to. So you have, I always have these conversations with my patients, and I'm very careful with my patients not to only use the word sleep apnea. I think that's important because we're not just looking for sleep apnea, we're looking for airway disorder and dysfunction. And a lot of patients have this upper airway resistance syndrome where we're getting excitation of the brain because of the resistance of the breathing, not because of apnea or hypopnea. And in all of that too, we have Dr. Guilleminault to thank for how we measure these things. But, at some point he had to pick the definition of an apnea and he had to pick the definition of a hypopnea. And the question then is, well, how related to pathology is that? Well, it's pretty, we know it's pretty well related because of all the studies that have been done since. But what was less understood was how related upper airway resistance syndrome was to a lot of the symptoms that people were having. So a lot of the psychosocial side effects that one gets from not sleeping well usually come from upper airway resistance syndrome. So decreased motor function, decrease in decision making, the affective components of being depressed or anxious also come from UARS. So, and it's important too that our sleep studies reflect that. So they need to be able to diagnose when the brain is being awakened by a respiratory disturbance. And I think we're getting better at that in our sleep studies, but some places I'll get reports back and I'm only looking at AHIs. I don't see any commentary on RERAs, respiratory arousals, and we need that information in order to make a proper diagnosis.
So then going back to your work with the TMJ, what can we do for these TMD patients? Because it's kind of a tragedy. I feel like a lot of these patients get overlooked. We just view it as perhaps it's just a psychosocial issue, refer them to mental health, give them a bite guard. I think this is a really underserved population.
Absolutely. And that's, maybe if you had a 12-hour podcast, we could talk about all that. What can we do as professionals to help our TMD patients? I think we can first decide in our profession to have better definitions. I think TMD by itself is a pretty lousy term. It's almost as lousy as fibromyalgia. What does it mean? For most people, it means either noise or pain in the head. Doesn't even have to include temporomandibular joint. It can just be muscular. So I think in defining the problems, we need to have better definitions. And so for me, the way that I separate out my definitions is simply, is it a muscular problem? Is it an intracapsular problem, meaning the bone or the cartilage and the ligaments? Or is it a neurological problem? And if you can separate them out, then oftentimes it will be many of those things, but you need to know which symptoms belong into each category, because one has muscular problems usually as a result of adaptive behaviors. To what? Well, to just about anything. Okay, so here's where one of the big arguments is in dentistry. Does malocclusion cause TMD? Well, what a horrible question when dentistry can't even decide what the malocclusion is or what TMD means. So at that point, you're already yelling at each other. So then let's take it to a better definition. Does having a malocclusion generate a muscular problem? Okay, that's a better question, but what do you mean by malocclusion still? In a class 3 patient, does the class 3 patient tend to have maladaptive jaw behaviors? No. They tend to close on a hinge. There's no real side movements. They don't really care if their teeth don't line up. I mean, if you talk to them, they're like, "Do you have a problem with eating?" No. But the teeth don't even line up. So I think then we can reduce the question down better. We get away from the idea of malocclusion. And so we can take all those studies that ever looked at class 1, 2, and 3 and TMD and throw them away, right? Because it doesn't help us. So then the next question is, do maladaptive behaviors, of the jaws cause muscle pain? Absolutely. So what are those maladaptive behaviors? Well, there are avoidance behaviors for inappropriate contacts between the teeth. There are maladaptive jaw positions in order to breathe better. Forward jaw posture in order to feel like they have a better airway. Forward head posture in order to feel like they have a bigger, better airway. That's going to hurt the muscles. So TMD and malocclusion, bad question. Maladaptive behaviors and musculoskeletal pain, absolutely. Because now, guess what? If you find out what the avoidance behavior really is, and you extinguish the avoidance behavior, you get a response to the muscular pain, and then you're winning now. So you have to discover those things within the system. Getting into intercapsular problems, a little more difficult and very much more controversial, and that's not going to be solved today or next year, maybe soon. I don't know. There are people that will bet their whole lives, their homes, and their families on the disc being the culprit in just about every aspect of facial growth and development and pain. And yet, we're willing to accept that 35% of the female population has anterior displaced discs without symptoms. Is that one of those normal questions? Like, do they fall within this normal curve because there are just so many people that have displaced discs and that is a problem? Is it the result of some other problem? Would we expect females to have displaced discs more than men? Well, we know that that's true, but why? Can we blame it on hormones? Relaxin as a hormone, for example, and with ligament laxity. Well, sure, you betcha. Maybe women have greater amounts of inflammation because of estrogen abnormalities. This is something that we postulated in the 2000s, 2009, I think. Maybe. But to blame the disc, it's difficult for me to get on the bandwagon because so much has been said about fixing the disc. So surgically repositioning the disc, and it's well known that it doesn't stay. Like it fails over time. So maybe repositioning the disc and then fixing the thing that caused it, which could be all this jaw posturing, the fit of the teeth, putting the lips together, etc. Maybe that would be beneficial. But even then, I don't know, because we're not approaching it that way. Really, the studies are do the disc plication, or in fact, we've arrived at the point where surgeons have just thrown up their hands and say, you know what, just cut it out, put it in a fake joint. It's fine. And I'm not there either. Like putting a fake joint in a 16-year-old, like no orthopedic surgeon in their right mind would give a knee replacement to a 16, 20, 30-year-old. Physical therapy, medications, sure. Total joint replacement, no way. But yet we do it. And That's because I don't think we understand. And I include I'm in the we. I don't think I get it all the way either, but I do think approaching it medically and functionally is the appropriate approach, at least.
Just a moment needs to be taken here. I think just to appreciate really just like what a venerable clinician you are here, because this is such a controversial topic that we know so little about. And it's such a beautiful thing to just admit how little we know about this. I cannot tell you. On a weekly basis, I get so many emails from, quote unquote, supposed TMD experts. And honestly, I kind of shy away from it because, quite frankly, I feel like I know so little about it, but we know so little about this topic that all we can really do right now is kind of speak in metaphors and pontificate on the matter. And I think what's really interesting about this idea, and you can probably agree with that, is it goes to show I have this theory that as our understanding of any disease progression advances, we begin to blame the patient less and less and talk more about the underlying etiology. But we know so little about TMD right now that we're really just blaming the patient, and we're saying that it's chronic stress, it's a mental health disorder, refer them to a mental health specialist. I mean, have you seen that?
Oh, absolutely. There was just a good friend of mine who's a dentist in New York. It's unfair to actually call him a dentist. He's really a oral medicine doctor. His name's Larry Gottesman. And Larry might be faulted for knowing too much at some point, but he brought this up today on his Facebook group. He talked about bone and its development and its association with all different kinds of other functions in the body. So one connection that people aren't readily aware of is how involved the nervous system is in bone, and how sympathetic activation actually leads to bone resorption through neurogenic pathways. So, I mean, when I learned that, I was like, what? Really? I mean, I didn't learn this in school. Why didn't anybody tell me about this? So you have these patients who have sympathetic drive, and you know who they are. They come into your office, they're overly sensitive to everything that touches them. When the sympathetic system is in overdrive, they always feel attacked, and so they're defensive. And the stress on the system causes depression and anxiety over time. So it's no wonder that our TMD patients have anxiety and depression. But is that just a byproduct of sympathetic overdrive? And in the end, is sympathetic overdrive causing condylar resorption in these patients? Well, quite possibly, because the sympathetic system's intimately tied into whether there's bone deposition or resorption, the ability of the joint to actually heal itself. So it's just so complicated. But I have to say that, there's some people that really do a great job at explaining joint function. I think Jeff Okeson is probably the best that we have. Dr. Nickel out of Oregon Health Sciences University. He's a very science-based researcher, but some of their theories on joint compression and the forces that are distributed through the joint and how that affects the disc and the jaw and the bones, really amazing stuff. So there are people out there asking great questions. It's the ones that have all the answers that I think, just as you said, that maybe we shy a little bit away from the people that have the answers.
So let me ask you this. What are the occlusal relationships and perhaps the interferences that might actually cause this muscular compensation that can lead to pain? Because if you also want to talk about an issue that I think has been really used in abuse, it's this. And I think it's been used to justify perhaps a lot of destructive prosthodontic work or destructive occlusal equilibrations. And again, there's some really great clinicians out there that are doing this formally, and then they'll now kind of admit, hey, I'm no longer implementing this. But, would you speak to that?
So, once again, I think we need to be able to analyze a patient correctly in observing these maladaptive behaviors. And sometimes 20 micron AccuFilm is not enough. Sometimes it is. I've had patients come in all kinds of distress, and I bust out my 200 micron Bosch paper, have them chew on it, and then my 20 micron AccuFilm, have them tap on it. And I look in their mouth and I'm like, whoa, look at that. That's a giant interference, on the mesiolingual cusp of the second mandibular molar, and I say something like, well, I don't know that this is going to help you, but let me adjust the palatal of your maxillary molar a little bit to get it off of that contact and an excursive chewing function. And I've done we're talking microns of enameloplasty, and I've changed their lives. Okay. So that is one patient. So now do I go out on the lecture circuit and tell everybody they should do enameloplasty, should they do equilibrations to solve myofunctional problems? It worked in one patient. It's worked in other patients too, but I'm not saying that that's what we should do in all patients. Let me take you through this kind of idea too. I feel like everything that I need to know about treating faces and bites and dysfunctional facial issues, I learned in removable prosthodontics. Everybody that I know of who's sane hated removable. I mean, I didn't like removable. I like my professor, John Bumer. He was a very smart guy and taught me a lot of stuff. And like I said, everything I learned there is applicable to what we're talking about. So what did we learn? Well, let me give you one example. When we take impressions for removable, how far back do we capture for our stone models? Well, do you remember? Like, what do we capture in the maxilla and the mandible?
Are we talking about the posterior vibrating line?
Yeah. So you have the posterior vibrating line, and you're supposed to capture the hamular notch, right? And then in the mandible, we capture the retromolar pad. And why do we do that? Because we want to make sure that our pieces of plastic that fit in the mouth don't bump into each other. And for retention, ask any orthodontist where they cut their models when they're trimming them, and they get trimmed to behind the second molar. They are losing at least 1 centimeter to 2 centimeters worth of diagnostic material. And why is it important? Because patients who have hypoeruptive posterior teeth, patients who are high angle mandibular growers, guess where they touch first? Second molars and behind. There are many people that actually touch from tuberosity to retromolar pad, but nobody knows because nobody takes impressions back there. But those are true interferences. And what does it cause people to do? It causes people to posture forward off of the contacts. When you look at the amount of nerve fibers in that area versus the nerve fibers in the second molar, it's crazy. Second molars, tons of nerve fibers, tons of proprioceptive fibers. Tuberosity, retromolar pad, very few. So does the body really know that they're running into the bones back there? Nope. But they would if they hit those second molars. All the brain knows is that things aren't coming together correctly. But if they posture forward, then they can get onto their teeth. So what we end up finding in patients that have these posterior interferences is we find that they have anterior tooth wear because they end up living out on their front teeth. So that's one aspect, for example, from removable, but it's one aspect that we don't look at, that we could look at the anterior tooth wear and the contacts in the mouth and all the wear, and we could build up front teeth and we could do occlusal equilibration in the posterior. But if you haven't handled what's behind it, it's all going to break down. So that's one example. And I need to give, credit to my colleague. Together, we kind of saw this as being a problem, as Dr. Jeff McClendon and also orthodontist Dara Chira, in looking at these areas behind the second molars. Dara saw it in kids. Jeff saw it in his adult prosthetic restorative cases, and I was seeing it in my surgeries. And we kind of come together and saw this problem. So, that's something functional that can go missed, and in which case all the other things, okay, so take this then, you have the same patient who has the muscular problems with the posterior interferences, you send them to a TMD specialist, what gets made? A splint, right? If they make a maxillary splint, the piece of plastic behind the second molar is now hitting what? The retromolar pad. I mean, if the tuberosity was before, now the splint's really ramming into it. Is the patient ever going to be comfortable on that splint? It's impossible for them to be comfortable on that splint. What's interesting, though, is if they then trim the splint up towards the first molar, then the patient actually might get some relief because the splint will open the bite up to get off the posterior contacts. But in our course, I talked about, Becca and I, in our course, I talked about chocolate cake. And I'll use chocolate cake now for dental appliances for splints. I like chocolate cake. You like chocolate cake.
Yeah.
Many of us love chocolate cake. But you know that if your neighbor's 10-year-old child made chocolate cake for you and brought it over, you have to call it chocolate cake, but you might not want to eat it, right? Versus going down to the corner where Chef Pierre is going to make gâteau au chocolat, and you're going to go to heaven in eating his chocolate cake. But either way, it's called chocolate cake, right? So at that point, just because you call it a splint doesn't make it something that you want to wear or that even works. Because the ideas behind splint fabrication are so different. You have to ask yourself, well, what are you doing with that splint? I mean, I've seen people wear hockey pucks basically in their mouth. And it's like, what part of nature is telling the clinician that the patient's pain is caused by a lack of acrylic in their mouth? It's like nature is saying, no, they need an inch of acrylic in between their teeth. I don't understand that. Let's go all the way back to the beginning where we talked about getting the lips together. If you take somebody that has maladaptive behaviors in their bite occlusion because they're too long and can't get their lips together, and now you throw a piece of plastic between their teeth, are you making it better or worse? You're making it worse, right? Because now they really can't put their lips together. And what are they going to try and do is they're going to try and push harder to get their lips together over the splint, distracting the condyles, overworking the muscles even beyond what they did before. So in many of those scenarios, that's bad chocolate cake. Having a splint in that patient, right? It's not helping. So then we have to go back and ask ourselves, well, how can I use a splint to make what's occurring in the mouth more natural, more healthy? And if we ask that questions, our splints become smaller and they contact just like they're supposed to in the textbooks with all the dots occurring in the right places on the teeth that are opposite the splint. And in those situations, maybe we get lucky and help them feel better. But again, going back to that high angle patient who has a long anterior face height, I don't think you're ever going to make that patient happy with a splint.
I appreciate the commentary because I think splints are misused and abused. And I think it just goes back to just again, as a profession, we just know so little, but I think we give them just honestly to kind of pacify the patient a little bit to make them feel like we're doing something for them. But again, I think that they're given to patients oftentimes when we don't really even have an appropriate diagnosis. We're not giving them to the patient for a thoughtful, thorough reason. And now my rationale for when I give splints, it shrinks and it's smaller and smaller and smaller. I do it so rarely, quite frankly.
Yeah, and I make them. I don't like to because I'm a surgeon, but there are some patients I don't feel like I can send them out to have a splint fabricated in a way that they need to diagnostically come to a conclusion. Like if I'm going to make a splint, it's simply diagnostic. It's a crutch. If I give you a good bite that doesn't create dysfunctional facial activity, do I fix your problems? And if I make that splint and they come back and say, I feel great, then I know their maladaptive behaviors are related to their occlusion and I have to fix their occlusion. I have to fix their bite. That's the diagnosis. Is the splint the treatment? Nope. It's really just telling me what needs to get done. But yeah, sometimes splint's not the way to go.
Just to wrap this up as a final question, what do you think are the appropriate indications for splints then?
Well, I can tell you when I use them in my practice. I use splints in my practice. One, as I mentioned, diagnostically. If somebody can wear a small piece of plastic that allows for protrusive and lateral guidance with all the teeth touching together at the same time in a position that allows the lips to touch passively, in that scenario, if a patient relaxes their jaw and they feel comfortable, again, then I know that maybe their bite is actually causing the maladaptive behaviors that are causing the muscles to be pained. The second scenario where I use a splint is almost the same situation, but I do it in an effort to decompress the joint. So when I have patients who have obvious resorption in functional areas of the joint, I don't know if that makes sense, but if I see resorptive patterns in the joint as a result of this maladaptive behavior, then if I can put a splint in and diminish the maladaptive behavior, I can decompress the joint and hopefully heal it or reduce the amount of resorption. And this is very important, for example, leading into jaw surgery, to be able to have a diagnosis and heal a joint that's in a resorptive phase prior to doing the surgery. So that's the other scenario where I will use a splint. There are also a couple people in the world who I have seen use splints to what they say to recapture the disc, to promote healing and development of the jaw joint. And I would never do that. I wouldn't know the first thing about doing that. Would I trust somebody to go to those people and have it done? Well, the two people that come to mind, yeah. Anybody else? I don't know, because I do know that there are some people that I know very well who do that and they don't recapture, or they generate resorption because of compression. So I think it's case choice, patient choice, good diagnosis, and getting it at the right moment that can allow for a disc recapture, for example, and doing it early. I mean, I would never expect some 40-year-old with anterior displaced discs to be able to recapture their discs when they've been beat on for, 20, 30 years. But in a younger patient where a click is newly developed and you can see that it's been displaced, maybe, for those couple people. But it's a technique that's not widely understood, so I don't know that I would send patients to just anybody to have that done.
Well, this has been a lot of fun, and I'm so glad that we finally had the opportunity to bring you on. Do you have any closing remarks?
I think my closing remarks just mimic, I would say what's most important to me is that I'm a healthcare professional, which means I need to provide health to the people that come to see me. My area of expertise is the face. So I need to be able to provide to a patient a healthy face, hence the name of our course, Healthy Growth, Healthy Faces. Like, I need to give someone a healthy face. Well, we don't use that term in our society. We don't compliment each other on having healthy faces. But it's a real thing. And it's changed the way that I practice. It's changed the way that I communicate with patients in such a positive way. I really enjoy helping people if I can provide for them a healthy face or health, so that when I'm diagnosing somebody, it's easy for me to look at somebody's face and say, you need jaw surgery, the jaws are misaligned. I have to put your bite together, make it wider, bring it forward, counterclockwise rotate it and put it all in the right place. That's easy to say. What's harder is to take the time to connect with your patient and their disabilities, what it means to them to not put their mouth together, what it means to them to not breathe well, and to say to them, I understand it, and let me show you why, you're going through these things, why you're experiencing this. And if we take into consideration your growth and development, and we take into consideration your disabilities and your problems, yeah, I can give you health. I can remove these things that are so troublesome for you. And what's fun is to see the light bulb go off, when you hear the patient, when you listen to them and their problems, and then you're able to say back to them, yes, I understand that. And then this is where it's coming from. And they're like, whoa, really? And in some cases, like we talked about, we can predictively say things even before they tell us. Somebody who can't close their mouth, you wake up with nasal congestion in the morning, don't you? How do you know that? Well, because you breathe through your mouth, your nasal mucosa swells because you're not breathing through your nose. You form this relationship, and then your treatments, like we said, are more long lasting, more rewarding. And so then all of a sudden practicing dentistry becomes this it's exciting and extremely rewarding. You asked about why Airway has become like so sexy in dentistry. I think you asked that earlier. It's because it's a part of the puzzle, it's the pattern. And when so you identify it in somebody, they're grateful. And then when you provide them this health, it's this pattern that you're fixing, and patients love it, and it's exciting for the doctors. So that's why Airway is so exciting now, is because it's a big piece of the health puzzle. Digital smile design, take it or leave it, but it's actually a functional action, smiling. So now dentists are treating something functional like a smile is far more rewarding. To treat something that is something functional, to give somebody a nice smile, it presents again that our smile is a representation of our health status. Are we healthy people? And it makes people feel good. So that's when you treat patterns and functional components, it's just more exciting, more rewarding, and it's more beneficial to patients. So I guess that would be my very verbose final statement.
Hey guys, believe it or not, ratings are one of the best ways that you can actually support this podcast. So would you mind just taking a second to go leave a rating and subscribe on either the Apple Podcast app, Spotify, or wherever you listen. And as always, send me a direct message on the podcast Instagram, which is Dental Digest Podcast.